I'm just going to run through a list of some common clinical complications or clinical issues that we have to at times deal with at various points along the trajectory. Certainly infections are a common problem, particularly in patients that require therapy or who have a higher disease burden or more advanced disease. The dysfunction of the immune system can be quite profound and multidimensional. So it may relate to impairments mediated through the leukemic clone in terms of cell-mediated immunity. By that I mean impairment of, for example, T-cell functioning. Sometimes the antibody levels in the blood or the immunoglobulin levels can be low. That's called hypogammaglobulinemia. Neutropenia, as I've mentioned, can be a risk factor for infections, which is related to how low the neutrophil count is and for how long it's low. Splenectomy, which is not particularly commonly done, at least not in my practice, but if it's required, and sometimes it is, I would say probably most often in the setting of autoimmune complications related to the disease, that can be associated with some increased risk for particular bacterial infections. And certainly, as I've mentioned, in patients who have a more either have been treated with certain types of chemotherapy drugs or have a more advanced disease sort of setting are at greater risk. So it's okay that we're gathering close in this room. We're not all going to be getting infections. It's something that though has to be monitored for as part of medical follow-up. The spectrum of infections is related, as I mentioned, to a variety of patient and treatment-related risk factors. There are a number of, in particular, chemotherapeutic regimens and, again, hypogammaglobulinemia that can increase specific types of infections, often bacterial infections, as I mentioned, with the low immunoglobulin levels and splenectomy. And there are a variety of additional immune problems that can be related to specific chemotherapeutic agents. I've listed some examples there. Fludarabine is a commonly prescribed drug historically and can result in a low lymphocyte count and increased risk of specific viral and other opportunistic infections. Alemtuzumab or Campath is a particularly immunosuppressive monoclonal antibody that leads to quite profound depletion of B and T cells and can be related to all of the above noted infections, plus sometimes some other rarer and sometimes very serious infections. And rituximab, one of the things we have to keep an eye on is the risk of hepatitis B reactivation in patients with a prior infection. So we do need to monitor and be aware of that. It's important to think about how one might best prevent infections as a consequence, and certainly there are a variety of treatments that may be recommended depending upon the scenario. Certainly preventative health is very important, and vaccinations are encouraged. There certainly is, I would say, a paucity of information about exactly how effective they may be, but most vaccinations are felt to be safe and can provide important protection against infections. Certainly, we recommend annual influenza vaccination. We recommend vaccinations for pneumococcal infections. And the other point about vaccinations, which comes up commonly in the clinic, is just the issue of certain live virus vaccines. The most common one probably being the shingles vaccine. And in very general terms, live virus vaccinations are contraindicated in patients with malignancies, with CLL lymphomas, and certainly those who might be more profoundly immunosuppressed going through chemotherapy. And so that is one that we have to be cautious about and, generally speaking, may have to avoid. In certain situations, we do recommend prophylaxis. That's often in the setting of therapy, where there may be particularly high risks of specific infections, and so we will recommend antiviral or certain infections for a particular type of pneumonia called PJP. And the other thing that at times comes up in the clinic is the potential to improve immunity passively by transfusing a blood product called IVIG. Certainly in Canada, there's quite a bit of IVIG that gets used for patients who are typically having recurrent or more severe infections, especially those that maybe are requiring repeated admissions to hospital for more serious or life-threatening infections, who also have documented low immunoglobulins. This is something that we are often find helpful in reducing the risk for infections. Historically, it's been given intravenously, and that is something that is covered under the umbrella of Canadian Blood Services. More recently, there's been a move and an ability to provide the product subcutaneously through home administration, and we'll hear a little bit more about this later in the meeting. Certainly, the group in Winnipeg has moved this forward and has a lot of experience, I would say, with this product. We're just gaining some experience in our own institution, but it's a potential option to consider in patients who may require IVIG replacement and may be able to avoid monthly hospital visits or some of the infusional toxicities. Oh, did I skip by one? Sorry about that. So moving through additional, if you like, disease-related complications, Richters Transformation is the development of a more aggressive lymphoma in patients with CLL. It's very often what's called a large cell non-Hodgkin lymphoma, diffuse large B-cell lymphoma. Occasionally other histologies can be present, much more rarely. And it's usually clonally related to the underlying CLL. Commonly presents with a rapidly progressing mass, so not necessarily a more diffuse progression, but you often see in a more isolated spot a change in a rapidly growing mass, oftentimes with B symptoms that I mentioned earlier. Sometimes a blood test called the LDH may go up and be a nonspecific clue. The incidence, fortunately, isn't too high, but it certainly is high enough that we see it relatively regularly in the clinic, in the range of 5 to 10% of patients. It's certainly more common in patients who have more advanced disease with previous treatment and who have higher risk genetic abnormalities. Patients, for example, with this 17p deletion that you'll hear lots about, I'd imagine, over the next day. And it does require aggressive chemotherapy treatments. It may require stem cell transplantation, and does have a relatively aggressive have a relatively aggressive course and poor outcomes. So it does require specifically designed therapy for it. I mentioned that commonly blood counts can drop, healthy blood counts can drop. There's a variety of reasons why that might happen that we go through in the clinic to try and understand why that might be, and they're listed there. As I've mentioned, sometimes the blood counts drop related to disease progression and an infiltration in the bone marrow that, if you like, overtakes the marrow and doesn't allow the healthy cells to grow and proliferate normally. We'll talk in a minute about some of the autoimmune complications. This is where the immune system becomes a bit, if you like, dysfunctional and turns on itself and attacks and breaks down red blood cells or platelets, rarely neutrophils. Sometimes, particularly in patients that have had prior therapies, certain specific chemotherapy drugs can lead to a condition called myelodysplastic syndrome, which is a clonal myeloid problem of the bone marrow that can be challenging to deal with. And on the thrombocytopenia side, sometimes splenic enlargement on its own right can lead to a drop in the platelet count, although that typically is of a more moderate degree rather than the more severe degrees that you might see with other complications. Autoimmune cytopenias are relatively common, and they can be a challenge to deal with in the clinic. Autoimmune hemolytic anemia is by far the most common, but ITP or immune thrombocytopenia can also develop in some patients. Overall, it's probably in the range of about 20% or so of patients at some point will develop an autoimmune complication. Autoimmune cytopenias don't necessarily influence staging, which we'll come to in a second, and the approach really requires a determination of whether the autoimmune problem is related to the disease, whether it's related to therapy, and whether or not it can be controlled with specific medications designed to counteract the immune breakdown of these cells. So typically, if there is no other reason to treat the leukemia, one can focus on the autoimmune complication. That's often with a drug called prednisone. Sometimes requires other treatments. There are some common ones are listed there, including rituximab. Sometimes splenectomy is recommended. And other times, more immunosuppressive drugs or other novel drugs that are designed to try and increase the bone marrow's production of these cells can be used. In general terms, if you can control the autoimmune process and the disease is relatively speaking stable, then one may not need to go ahead with chemotherapy for the disease. And in other situations, it may be that this is a recurrent problem that is being largely driven by the underlying leukemia, and that is an indication for treatment in some patients as more refractory autoimmune complications. I won't talk too much about second cancers because there's a whole session dedicated to this tomorrow, but suffice it to say, there does appear to be a slight increased risk of developing second malignancies in patients with CLL. This may be as a result of the, so if you like, the immunosuppression or lack of impairment of immunosurveillance. And there's sort of large population level data suggesting that this is indeed a problem. Really, I think the key clinical issues are to make sure that there's an awareness of this among healthcare providers that are involved in your care. Make sure that risk factors for other cancers, that screening procedures and preventive health procedures are strictly adhered to try and make sure that this is mitigated as early as possible.